Thank you for tuning in again. Today I'm going to be giving a small presentation about gestational breast cancer. It was a topic I had to cover recently. So the definition pretty much for either gestational breast cancer or pregnancy-associated breast cancer, PABC, is when breast cancer is diagnosed during pregnancy or 1 year postpartum or when patients are lactating. And from an epidemiologic standpoint, it is the most common cancer in pregnant patients. It is rated right now 1 to 1,000 to 1 to 3,000, depending on the literature that you read. The increase that we saw from like 1964 to now has been hypothesized due to a delay in first childbirth. And some other interesting facts. Gestational breast cancer initially in literature actually used to believe that termination was the best option once the breast cancer was diagnosed. And this is no longer the current thought in the field. So going over some pathology, so in regards to breast cancer, which is a huge spectrum, infiltrative ductal carcinoma is the most common type of breast cancer within pregnant populations. And I have a little slide right here kind of showing, how the dysplasia will occur within the ducts. And right here, I also have from like a histopathologic standpoint how they grade it. So, you can have grade 1, grade 2, grade 3, and that's dependent on, tubule formation, the nuclear atypy, and the mitotic figure count. So, combining those, you can either come up with like a scalar system and will determine whether or not they're grade 1, grade 2, or grade 3. And looking at this is the histology slides that are representative of a grade 1, 2, or 3 infiltrative ductal carcinoma. These are pulled from UpToDate. So to start off with like some physical exam findings, so this is a slide that kind of goes over some different presentations that can be synonymous with breast cancer. The issue is, however, that during pregnancy there are physiologic changes, specifically hypertrophy as well as breast engorgement, that can make these symptoms kind of non-reliable for patients. And from diagnostic standpoint, from imaging, the first one that you're going to be doing is an ultrasound, and this is an easy way to determine whether the mass that you felt is either a simple or a complex. It doesn't require any radiation, and then you can go beyond that and you can do a mammogram, and this is the best diagnostic test for this. The reason why is because when the ductal cancer actually goes outside, there's some fibrotic change, and that fibrotic change results in calcification, and that calcification obviously is easily picked up by x-ray. So this is a good way to determine whether a person has infiltrative ductal carcinoma, which is the most common type of breast cancer. There is a small level of radiation from a mammogram, but this should not be a reason why a patient should not be getting a mammogram, because it would be safe for baby and there's lead protection. That being said, though, if the ultrasound and mammogram are non-contributory to the diagnosis of gestational breast cancer, then it could be reasonable that a patient can go for a breast MRI. This is not a superior imaging technique, the mammogram is, but it's not superior due to the fact that there's an increased amount of like water within like the breast tissue during the engorgement phase. And then secondarily, there's always like some small level of heating risk when you are doing MRI. And the last imaging technique, even beyond the diagnosis of breast cancer, is to look for metastatic disease. And sometimes the disease can go to the brain and the liver. That's where I started. And that's best picked up by a full body MRI. And on the right as well, you can do a bone scan, and the x-ray from the bone scan should not be prohibited in pregnant patients just because they're pregnant. So that's two ways to determine where metastatic disease might be from the breast cancer and determine how you can best treat. And now I'm going to spend most of my talk really talking about the chemotherapeutic aspect, which is what really is interesting to me kind of on this talk. So from a chemotherapeutic standpoint, we have to understand that maternal physiology actually changes during pregnancy, and these are kind of 5 of the main pillars that really are associated with it, and each of them have different effects. So renal plasma flow will affect the amount of drug, decreased plasma albumin affects binding capacities, blood volume affects concentration, hepatic metabolism affects activation. So you have all these different things that really will modulate the way chemotherapy is delivered and retained in the maternal hematologic system. And then there's also the fetal development phase. So in fetal development, and this is pretty obvious, you have, your chemotherapeutic options, and at the embryonic period, from conception to week 8, you can have huge congenital malformations up to 20%. So it's not recommended to actually start chemotherapy during that phase. But during the fetal period from that week to 38, technically is when you can be starting to give chemotherapy. Obviously, the cutoff is going to be around 34, 35, and I'll explain why afterwards. And then there's the postnatal period. But it should be important to note that you should not be prohibiting patients from starting chemotherapy during the fetal period, because those patients will have worse outcomes because they have delay of care, even though there's medications that actually have good efficacy for fighting cancer while not causing harm to baby. And then there's monoclonal antibodies. So, when we diagnose breast cancer, it's like HER2, PR, and ER. And HER2 is EGFR, and this uses the trastuzumab monoclonal antibody. So I'll be going into that a little bit, and we should not be using that antibody. So from the chemotherapeutic agents, there's 3 main ones, and 2 specifically, doxo and cyclophosphamide, that are used for managing gestational breast cancer. And to throw back, because I don't know if you remember the sketchy videos or not, doxorubicin, it inhibits topoisomerase 2. This is the molecule that really helps DNA spin and coil so it can fit into nucleus. So this is an important thing to be providing them. At the bottom of the slide, I've listed some important things in regarding what the effects are for these medications. And for doxorubicin, there's increased risk of preeclampsia after 28 weeks of gestation, obviously IUGR, but the most common one I think is maternal cardiotoxicity. So everyone knows that doxo has cardiac defects or cardiac effects, and some of these can be presented as either SVT, dilated cardiomyopathy, abnormal EKGs. But when looking at huge studies and looking at the effects of doxo on pregnant patients versus non-treated pregnant patients, 15.9% were associated with cardiac death versus 15.1% were associated with breast cancer death, which was non-significant. So it is superior to be giving doxorubicin to these patients. The next medication that is provided is cyclophosphamide Cytoxan, and this affects the cross-linking of the DNA right here, and that's super important as well in order for DNA to kind of be stabilized during the folding process. And the most common thing, and should everyone be able to tell you this, is hemorrhagic cystitis, most common effect of Cytoxan. And you give Mesna for this, and Mesna is actually safe during pregnancy, so if you had to reduce the risk of hemorrhagic cystitis, you can definitely give Mesna. There's no issue with that. There's also known pulmonary toxicity, and this medication, however, is contraindicated during pregnancy. Other things that Cytoxan are used for actually in pregnancy in general is if you have refractory ITP, you can give this medication or you put it on differential, as well as severe lupus. And the last thing as well is these medications, you should be giving them virus screening. So hepatitis B screening should be done on these patients in case to reduce you're going to have immunosuppressive effects from these medications. So it's important to make sure that they don't have any lingering latent viruses. And then we have taxanes, and taxanes stabilize microtubule polymers. So, when you're going in from anaphase to telophase, the telophase can't actually exist anymore because they're stuck in that stabilized, polymer structure. And, the common things are the peripheral neuropathy, where you remember Jane and Tarzan had the gloves on their hands, if you remember the sketchy video. And interestingly, this one also, so this detected in 7 days in cord blood sample, but not 21 days post-treatment. And that's super important for when we're considering actually stopping chemotherapeutic agents. So you can still detect it after you give taxane 7 days after in cord blood, but if they wait 21 days, they're no longer able to detect taxanes. And then jumping next would be really the monoclonal antibodies. So this one, the main one really is trastuzumab. There's a few other ones, there's a few VEGFs and stuff like that, but really trastuzumab is the one I want to focus on right now. And this is one that binds to HER2. It is effective for managing breast cancer that's HER2 positive, but super not effective when the patient's pregnant, because HER2 is actually expressed on fetal kidney. And so if you were to then use trastuzumab, it is a small monoclonal antibody that easily crosses the placenta and then can actually go in and cause oligohydramnios. And that's the etiology of how they can get oligo from trastuzumab. That was discovered on patients who were on trastuzumab for studies, subsequently developed pregnancy, and then were assessed and found oligo. Another small fact is it synergizes anthracyclines. So if you have doxo and trastuzumab on board, there's a synergistic effect that can cause cardiotoxicity. And now for some general studies that are the reasons why we're using the regimens that we're using. So outside of pregnancy, the regimen that I've found was CMF. So this is cyclophosphamide, methotrexate, fluorouracil. And as most people can tell you, methotrexate is a suboptimal medication during pregnancy, especially if the pregnancy is desired. So this was a huge meta-analysis over 100K patients, and it was shown that AC, which is anthracycline cyclophos, is equally effective to CMF, and there's actually decreased recurrence risk when you're looking at non-treatment to AC treatment. So that's what those 10-year recurrence and the 10-year mortality rate is associated with. Then there was, the big question is like, okay, so what are the pediatric effects? So mom is okay with it, and it does work for breast cancer, but like, what are the pediatric effects? And there was a 2015 paper that came out in NEJM that was showing that, out of an N of 129, not too huge, but N of 129, they were showed that there was no birth weight, cognitive development, or cardiac defects in those patients. And jumping on a little bit more, there was a few more studies that were acuting like fluorouracil. So the FACT studies are fluorouracil, anthracyclines, and Cytoxan. And those were also showing that, there were no stillbirth, miscarriage, or perinatal deaths. So it is reasonable to be giving these patients medications because they don't have an increased risk of malformations. Of course, in the study, there was one subarachnoid hemorrhage at 38 weeks. There was a T21, a club foot, a bilateral urethral reflex in like different patients. But in general, there was no difference in the study, in the prospective versus the control arm. And then there was also lastly a multicenter cohort study that was receiving taxanes. So taxanes is a controversial subject within gestational breast cancer, whether or not to use it. Unclear benefit. Really tough actually to figure out, and I wish I could explain more, but at least from this study and like a few other studies, I'm under the impression that really taxanes, A, are non-inferior, and B, might have potential upside if the breast cancer is metastatic. So if you have a metastatic positive patient with breast cancer, I think it potentially might be reasonable considering addition of taxanes due to the fact that there have been so many studies that have failed to show that there is increased risk of malformation. And then now we know, what the chemotherapeutics are. We kind of know what the studies are that showed why it's effective. And then lastly is like how we're going to be doing this in a management time frame. So just kind of really going out, if you have your chemotherapy and this is your dose times regimen, and you can start this really at like 18 weeks, a little bit after that. And this dose times regimen is something that is generally referred to as a higher frequency, less amplitude. So you're giving them chemotherapy more frequently, but you're not giving higher dose. And this has been shown to be superior in pregnant patients. So that's what we do. And we stop it at 34 to 35 weeks gestation. And the reason why we stop it at that point is because there has been shown to be, fetal leukopenia. And if you have, or neutropenia, and if you have that in the baby, that's like obviously suboptimal when they come out because they can't fight infections and withstand the environment. So, going back to that taxane portion where they were able to find, the chemotherapeutic at 7 days, but not 21. So the common conception right now is we really stop these chemotherapeutic agents at 34 to 35 because we give 3-week time frame until they start developing like spontaneous labor, which is like at 37, you have an increased likelihood of developing spontaneous labor. So if you stop it at 34, you get 3 weeks, or 35, you get to 38. The next thing as well is delivery. So this is only cesarean sections are indicated only for OB reasons. There should not be general cesarean mindset just because the patient has gestational breast cancer. And then in the postpartum period, we just restart chemo after 7 days, and then reiterating that, Cytoxan should not be used during breastfeeding because it can pass to breast milk. So thank you for my talk. Kind of a brief overview of gestational breast cancer, pregnancy-associated breast cancer. I hope you enjoy, and stay tuned for more talks in the future.